All right, man. We talked a little bit before, but still, can you like introduce yourself a little bit?
Yeah, sure thing. Yeah, so my name is Byron Miller. I guess technically Dr. Byron Miller. I'm a physical therapist. Recently made the move out to Detroit, Michigan. Prior to that, I've been in Salt Lake City for a while. My focus is on tendons and specifically rotator cuff tendons. I'm a bit of an obsessive on those things, and so that's been kind of the last I'd say a year or two that I've been primarily focused on those things. Recently wrote a protocol around kind of handling rotator cuff pain from a tendon-based perspective. And so that's what I'm up to these days.
Nice, nice. So, uh, as usual, like what got you into tendon? What got you into the rotator cuff?
Yeah. So a bit of a long story. We'll try to keep it appropriate time-wise, but always been really into science. Early on, I thought I was going to go into medicine. So I did a pre-med, and then I spent a couple years in medical school as a young man. Decided that wasn't for me. Zigzag pathway, did a bunch of outdoor work, some adventurous stuff, and ultimately came back to science, went to PT school. And when I was in PT school, we were pretty the continuum model from from Jill Cook, and that was predominating then. And what I found really interesting was that one, that was a pretty new understanding, a move away from this like tendonitis idea and into this kind of continuum model around like tendinosis possibly and tendinopathy on a larger scale. But then when I went into my clinicals, I found that my knowledge around continuum and around the fact that we need to progressively load these things was not very common. And so I did a presentation around patellar tendinopathy based off an article from Ebony Rio when I was in my orthopedics clinical. And it was clear that just having read those articles, I was a little bit more up to date than folks that had been around for a really long time. And so that was really interesting to me that the field was changing and that there was a really significant shift in the way we were treating a really common problem. So that was kind of the beginning of it. I continue to be really interested in tendons, especially the idea that things were kind of constantly changing. We're kind of constantly learning new things. I don't think that's the case in a lot of other conditions, back pain, those things. Like I think we have a decent understanding there, but tendons, it felt like was really rapidly evolving at the time where I was becoming a clinician and kind of developing my skills. So I was really interested in tendons, but I actually got a bit jaded of the orthopedic world. So my first year I spent in the home health world actually, and I actually came across a couple conditions even in that setting that were more tendon based. So historically, we talk about a trochanteric bursitis or a lateral hip pain. And that had historically been looked at as just an inflammatory process as well. I did some further research, and it turns out it's often a big contribution from glute tendinopathy. So I was like, this is really interesting. Tendons maybe matter a lot here. And I went back into orthopedics and I was working at the University of Utah. And in a traditional orthopedic setting, you see a lot of shoulder pain. It's one of the most common things that you'd see. And I really didn't feel comfortable treating it at that time. I didn't feel like my education had appropriately prepared me. So I actually was at home. COVID happened. We got sent home. I was treating virtually, and I had probably three or four people every day on my case or on my schedule that were shoulder cases. I was like, I gotta understand these things better. So I started doing some reading, and I came across a paper by a guy named Chris Littlewood, and he's probably my favorite author. And the reason that I think he's my favorite author is he approaches rehab from a very human standpoint. So his main point was that one, we know that most chronic shoulder pain, probably greater than 70%. He has a recent article in Journal of Rheumatology that says that greater than 70% is going to be tendon based. And if we know that it's tendon-based, then it's particularly a rotator cuff tendinopathy, then we know that we want to apply the same principles that we would to any other tendon to the shoulder. And so his point was that one of the biggest issues is the ability to get someone to do exercise consistently and to be loading the tissue consistently. So in a study, he compared single exercise therapy versus traditional physical therapy for rotator cuff tendinopathy. And at 6 and 12 months, the results were a wash. Everybody got better. So that was really, really illuminating for me that we could maybe simplify things a little bit and we could focus on providing appropriate loading, appropriate recovery, and then doing it again. And maybe it was that simple. And I started to apply those principles to the rotator cuff, and I started having a ton of success. And that kind of was the thing that really like endeared me to tendons and rotator cuff and really kind of made this something I was really excited about because I didn't see a lot of other folks doing it, but the literature seemed pretty consistent that tendinopathy was a big driver here. So since then, I've been running this idea of simplistic loading to the shoulder from a tendon-based perspective, continue to have a lot of success. And then ultimately that led me to kind of solidify the process that I've been using into the rotator cuff protocol and now to focus on mostly coaching for rotator cuff tendinopathy. So that's a long answer, but that's really why I got into this stuff.
Nice, nice. I love it. I love it. Um, s- I don't have a PT background, but like I came from Taiwan. Back in Taiwan, we need to do like everything on our own. So I have SFMA,
Mm-hmm.
all that stuff. What's interesting is like I could say I'm pretty good at foot ankle scoliosis or SI joint, but when it comes to shoulder, I'm just like I don't have a clue. So like it's actually the same. I don't have a clue when it comes to shoulder. So
Yeah.
am I understanding correct? Like the traditional approach to what you're saying is the traditional approach to treating a shoulder compared to like focusing on rotator cuff, the results actually about the same?
That's what the study showed. It was called the self study. I think it's 2013, 2014, somewhere around then. And yeah, that's what they showed. And it was called the self because it was a self-managed single exercise program. So they actually like just had a couple of check-ins with physical therapists, the self-managed group, but they were just using a single exercise in the direction that the patient was experiencing the most pain. So for most of that group, it was in shoulder abduction, just pushing out to the side. So they just had them use like a can of food or like a water bottle or something like that, and just progressively load that over time. And yes, that was the result was that they both did about the same. They both were successful.
All right. So the following question is like, I mean, obviously like there's like when it comes to like Achilles tendon or patella tendon, there's
Hmm.
movement assessment for that. But what about rotator cuff? Like how do you assess if it's a tendon pain or not?
Yeah, that's a great question. So there's how do I assess if it's a tenant? I think that the word I've come to is ultimately simplifying things. So sometimes you're going to see like reductions in range of motion that are related to the soft tissue and less the joint. So it's more actually like maybe that tendon is actually stiff, maybe that the muscle is having some issues. And so a lot of times if the range of motion actually might be more of a symptom, the reduction in the range of motion. Really, what I'm looking at if I'm going to diagnose a tendinopathy, I want to rule out that I've got frozen shoulder, and I want to rule out that it's an AC joint, and I want to rule out that it's like traumatic or an unstable shoulder. Like those would be the things that wouldn't be necessarily. Sometimes you can have components of tendinopathy in those folks as well, especially the unstable ones. But if it's none of those things, then it becomes subjective. Like, so I'm looking at the subjective, and with the subjective, one of the biggest things I'm looking for is that next day pain. So a lot of times with these shoulders, the textbook is what we're gonna hear is, yeah, you know what? I start doing something, it hurts a little bit. After I get warm, it feels fine. Then the next day, it feels terrible. That is pretty classic for tendons. And so my line for that is tendons are liars in the moment, but they'll always tell the truth the next day. When I hear that in a subjective over and over and over again, that starts to really get suspicious that I'm dealing with a rotator cuff tendinopathy here. The other thing I want are two things. I want to have localized pain. So I don't want like vague shoulder pain. So the other, like when we're looking at the other diagnosis of tendons, if we're talking about patellar tendon, we're talking about glute tendon, we need to have specific location. We need to have a subjective that fits. And we also need to have load-based pain response. And so that's the other thing that I need to see from a shoulder. I need to see that if I load that rotator cuff, I can cause pain. If I can't cause pain adding load to it, I'm going to be suspicious that I'm not dealing with a tendon maybe because I need to see that as well. So for me, I'm usually using isometric based testing and I'm going through a series of positions and motions and trying to find one that is provocative because we know that the special tests for the shoulder are not very good. So all of the tests, empty can, full can, all of that stuff, not really good. So and ultimately they're load tests. So why not just try to find some place where you load it and it hurts? And that is basically what I want to say it's the British Society of Primary Care, something like that. They have a flow chart, and it's basically what I just described. Rule out AC, rule out frozen, rule out unstable, and then you go into it's basically like a lateral Job test is what it's called. You kind of get into this position and then you're really loading that posterior cuff pretty significantly. And if you have pain in that, it's basically a rotator cuff tendinopathy. So it sounds overly simple, but when you look at every other tendon, that's basically how we diagnose these things. There's obviously some other differentials, maybe at the Achilles and those things. But for the most part, it's localized pain, the ability to get a pain response with load, and a subjective that has either an increase or a decrease in activity at some point. We need to see those three things. If we have those, I start to feel pretty confident.
Nice, nice. Um, as you know, like mainly work with basketball player.
Yeah.
Basketball player also have a lot of shoulder issue.
Really? Okay.
Yeah. Like I mean, probably all type of athlete have some sort of like shoulder issue. So in your experience, does this also like this a lot of shoulder issues, mainly rotator cuff issue, is this also implied to like athletic population?
Yeah, definitely. I would say that I cut my teeth on general population. That was who I was seeing initially. But as I've been doing more work, had lots of opportunities to speak with sport coaches and folks, PTs and strength coaches working in performance. And so I've actually spoken with water polo athlete or water polo strength coaches, handball, tennis, baseball, Muay Thai, they're all experiencing some rotator cuff tendinopathy type stuff. So yeah, it is definitely, especially when you've got high volume of activity or maybe high rate activities. Those groups definitely. I think in your younger athletes, maybe we have a little bit less of it. It definitely seems to increase as we're aging, but you're also seeing that those athletes are kind of they're at the extremes in terms of what they're exposing the shoulder to. So definitely seeing some of these things in those populations for sure.
Hmm. And so recently, like basketball or football population, we talk a lot about, not recently, but like there's more and more. So we talk a lot about Achilles
Mhm.
tendinopathy, patella tendinopathy, quad tendinopathy, like and people are talking, like you said, rotator cuff. Like, do you think that's a thing that like just pop up in the past like 10 years, or it's always a thing that like we kind of finally understand what are we dealing with?
I think I tend towards the latter. I think that at least, and this is maybe my bias, but I think the literature supports it as well. I think we are starting to understand it more, understand what we're dealing with, basically. Historically, we were using, and some folks still are using, it's like rotator cuff related shoulder pain. And I'm like, yeah, okay, that's a mouthful. Like, what does that mean, really? Like, I don't know what that means. So the idea that and also we don't we don't say patellar tendon based pain or something like that. We say patellar tendinopathy. So I think that we are starting to understand this, and I also think that the PT world is starting to move this way as well. There was this a clinical practice guideline put out by the APTA, and I believe it was last year, but it's specifically for rotator cuff tendinopathy. And it's the first time they've ever put out a clinical practice guideline specifically titled rotator cuff tendinopathy. Before that, always been shoulder pain, rotator cuff related shoulder pain, those types of things. So I think we're getting clarity, but there is a lot of pushback within within the world and within the shoulder world, and folks that are saying no, we can't say it's a tendon, it's still just these things. And maybe they're right, that might be the case. I think that there's potentially benefit in us simplifying this and saying, hey, this is probably primarily a tendinopathy, because I think then it's a lot easier in my experience to educate and to have someone understand what's going on with their shoulder. If I can explain it from this tendon perspective and say things like tendons are liars in the moment, but they're gonna tell you the truth the next day. If we can talk about like the fact that you had an underloaded experience and then you did too much and that's kind of what caused the issue, I think that it helps to look at it through that frame. It makes sense for me, and it makes sense to make sense for the people I work with.
Nice, nice. So, uh, maybe that's why like we're both of us at the beginning of our career, like we struggle with shoulder at the first place, because probably no one really know what's going on.
This is honestly, this is a fundamental belief of mine, is like, I think that because it looks complex, we're kind of starting with the idea that it is complex, and it is in the sense of it's got lots of ways of moving and things, but that doesn't mean that the intervention has to be complex. And I think like when you have a fundamental understanding that that there might be a specific tissue that's driving symptoms, and if you know how to speak to that tissue and we understand that, then to me it makes sense to do that. And I think it also really helps to, when things are vague, it's really difficult to know where to start. But if you already understand tendon and tendon rehab, then it becomes a lot more simplified. Okay, let's find out, can I load this shoulder in a way that hurts it? Can it can I do it in a way that is tolerated and then responds well within 24 hours? If that's the case, well, that can become my intervention. So that's what I've done for the most part. And then it's a matter of just gradual return and then respecting some particular angles that might influence the tendon more than others. Instead of looking at kind of as like a big shoulder, it's like, oh, or I've got a specific irritated tissue that's going to get irritated in certain positions. If I stay mindful of that, things get pretty simple.
Mm. All right. So earlier conversation you brought up like Joe Cook's like rehab protocol
Mm-hmm.
in terms of like low. I think she, maybe I'm wrong, but I think she mainly focused on lower limb. But like,
That's my understanding. Yeah.
yeah, at the end of the day, tendon is tendon. So you mentioned this on your rotator cuff protocol, but
Mm.
uh do you still use kind of the same concept when it comes like return to sport?
Uh, can you elaborate on what you mean? Like same idea as for a lower extremity? Is that what
Yeah,
you
yeah.
mean?
For do you like the
Yes.
ISO, wait, isometric, isotonic, and
Hmm.
energy storage and return to sport? Do you use the same
Yes,
concept to
I do.
shoulder? Yeah.
Yeah, I do. I do. Yeah, very almost the same. And sometimes you can be doing a little bit of some concurrent, right? We have this idea of like I think Peter Moliaris has been talking about this especially recently, like running some plyos, like at the same time potentially. And so I don't think that it always needs to be like 100% this phase, then this phase, then this phase. Very, very dependent on that individual, especially if they're tolerating stuff. Like if you had a basketball player that was tolerating a certain amount of playing. Like I want to maintain that for sure, even in the early stages, and then we'd be expanding that over time. But yeah, for the most part, the way that we're doing it is kind of if we got a really provocative shoulder, we might be starting with those ISOs to kind of calm that down to manage that fire, then moving into heavy, slow resistance, just like we would at the patellar tendon, and then I think that a slight difference is we're moving into more compressive positions as well. So that's a slight difference in that we're trying to get into these positions that combine compressive and tensile load, and that's going to be that later stage, mid to later stage. And then, as you said, we're gonna increase that rate of force. So we're gonna start to do maybe some quicker movements, some faster tempos, and then maybe moving into something like plyometric push-ups, those types of things, net throws to get to that end stage.
Nice, nice. Um, in the past few years, like pro sport been struggling with this tendinopathy, tendonitis thing.
Mm,
Um, I guess like, and then like we started do ISO. We started learning more about like Joe Cook's protocol, Ebony Rio, to
mhm.
like lower limb to like shoulder, like rotator cuff, like the protocol you did. Um, and then there are some people talk about like although the symptom is tendon pain, but maybe like there's other issue that is causing lower limb tendon pain. And when we like the way we used to treat shoulder is like, all right, if this guy has shoulder pain, we check their thoracic spine first,
Yeah,
check their cervical spine first. Um, do you think there's still value in checking that?
definitely, definitely. I think yeah, that would maybe is something I would have added earlier. Like if I'm dealing with shoulder, I want to rule out neck too. I want to make sure that that's not what we're dealing with. I think that especially in athletics where you might need to be able to get into certain positions with ease. If you're not able to express those positions appropriately, then you might be experiencing some more significant stressors at the shoulder as a result. So I think, and this is speaking with some strength coaches in things like water polo and baseball and those things, and physios as well, that often they're gonna make sure that people can access those positions. So if I had somebody with a really stiff thoracic spine that needs to get into some extreme positions and they can't get there, and maybe they're forcing the shoulder into a more extreme position as a result, then I think that that could be worthwhile. I will say that I tend to think of that as a second order thing. So I tend to think like, hey, the first issue is probably a load based issue. And so in pro and collegiate sports, the schedules are not dictated by tissue tolerance and tissue capacity. They're dictated by capitalism. So, a TV contract, all that type of stuff, right? And so that's really often, I think, what is driving a lot of these things in those populations is these just incredibly demanding schedules, the incredible load demands. And so I think maybe like that honestly in season becomes management basically, and then off season can be rehab. So I think that's more what I'm looking at kind of at that phase would be like, hey, what's the load like? What possibly can I do to help manage symptoms in a season? And then afterwards, it'd be like, let's increase tolerance and capacity of those specific structures so that then when I return to sport, I perform a little bit better versus the biomechanics of this led to this issue. I got to fix the biomechanics and then it'll go away. I don't know if that's the case.
Nice. I love it. I love it because I remember having conversation with different people about like the biomechanics and like the local tissue.
Mm-hmm.
And like we talk about, like I'm dealing with athletic population, not just basketball, sometimes like track, sometimes uh different sport. But yeah, there's like they have like game like 2, 3 games every week. It's just impossible to like fix it right away.
Yeah,
And yeah, tendon like the isometric or load issue is actually a better like a faster way to like help them get better.
100%, 100%. Because yeah, I completely agree with that, and it's one we've got some evidence around too, right? Like, hey, it just the idea of like mechanotransduction. It's like, all right, apply load. This cell then converts that into, production of different proteins. Like, we know that that is occurring. Like, I can hang my hat on that a little bit more than like a vague biomechanic thing. I'm not sure if I'm able to modify. Like,
Yeah.
that's my bias for sure.
Yeah. Yeah. I love it. Um, all right. Obviously I came from basketball, so a lot of my stuff will start from lower limb.
Yeah.
Recent years, like we're talking more about like, all right, calf strength. Is a calf strong enough? Is a quad strong enough?
Mm-hmm.
Right? Um, when it comes to Achilles tendinopathy or patellar tendinopathy or tendonitis
Mm-hmm.
whatsoever. Let's talk about rotator cuff.
Yeah.
How strong is strong enough?
That's a good question.
Stupid question, but
Well, no, what just came into my brain though is I don't think I read the study, but I think it was Jared Powell that put it out, and it I think it's the gist of it is increasing increasing strength is not enough. Is not really like is not going to fix shoulders basically, and that's a really gross oversimplification of I didn't even read, but that's my understanding. So my thinking is like your it's kind of about like the needs. So if I have someone who has extreme demands on the shoulder, I need them to have a buffer capacity and a tolerance that exceeds what they're going to be exposed to. If I have somebody whose biggest shoulder movement is just putting up a glass above them, then they need to be stronger than that movement, right? If I have somebody who's got extreme forces because they're pitching or doing something else, that's going to need to be a lot more capable. That said, capacity is only one side of this, and the other side that gets missed is tolerance. And so sometimes, so I'll define those. My simplified way of capacity is the ability to do something in the moment and not break right then. Tolerance is the ability to do something and not feel broken the next day. A lot of rotator cuff tendons lack tolerance. And so we're just people are focused on just building capacity, but if you're not actually paying attention to that next day symptom, you might actually be driving a little bit more pathology. So I think it is definitely important for us to be getting, strength at appropriate levels. Symmetry is probably limb symmetry is probably a good idea, right? But also, we really need to be looking at, hey, when I expose it to these things, what's the response? So I need to see what that response is, maybe a few hours later, but more importantly for tendons, that 24-hour response. So that's a long way of saying I definitely think we need strong shoulders. Absolutely. But we also need to look at, hey, when we're imposing these demands, we're imposing these stressors, how does it actually respond? And can it consistently tolerate what I'm exposing it to? That matters a lot more to me. And then ultimately, I'm trying to get to a place where I've created this buffer capacity to where anything I expose it to or is basically fine. So the gym or whatever it is exceeding what it's going to be exposed to in life or in sport, such that we're not really having those overload moments anymore. Does that make sense?
Yeah, yeah, yeah. All right. Last part of this podcast. Obviously you did a really good rotator cuff tendon protocol.
Appreciate it.
What are like the next topic you're interested in?
I didn't know this one was coming. Um, I'm not sure right now. I'm not sure. I I'm interested in a lot of things. But I think rotator cuff might be where I'm going to stay for a while right now.
Nice, nice.
I'm the need and there's a few reasons. One, it's actually there's the greatest, and I'm gonna get these terms wrong, but I think it's incidence. I'm not a stats guy, but rotator cuff tendinopathy is the most common tendinopathy in the world.
Well, really? I did not know
Yeah.
that.
Yeah. So there's a I think it's from Nature, but it's on tendinopathy and they have the percentages, and this one's 5.5%, and it's higher than every other tendon.
Yeah,
I
I would
can't
imagine it would be knee, but
right? And and it's another case. So they said it's 1% of visits to primary care from folks over 45 are going to be for shoulder pain.
hmm.
70% of those are rotator cuff tendinopathy.
Oh, okay, okay.
So the actual like global burden is huge. And the other thing that is making me very think about that this is the thing I want to stick on is that I don't see in other tendons the jump to extreme medicalization as I do in shoulders.
True.
So if somebody goes in with a patellar tendinopathy, you don't immediately get an MRI, get a corticosteroid injection, get a PRP injection, have surgery right away, right? You don't really see that in the patellar tendon world. In the shoulder world, in the rotator cuff world, that's almost all you see.
Yeah, yeah.
It's an epidemic, in my opinion. And I just spoke with the guy yesterday. He's actually a physician's assistant who had experience in orthopedics, and he went in for a little bit of shoulder pain, saw an orthopedist. His his physical exam was clean, range of motion looked good, all of the special tests were clean. So the ortho says, "Well, we got to get an MRI." They get an MRI. It shows a slap tear. They decide the surgeon decides, well, that must be the driver of your pain. He's scheduled for surgery 2 weeks later, has surgery 2 weeks after the initial consult, basically, never got offered physical therapy. In that surgery, they ended up doing an AC joint resection, a subacromial decompression. They repaired two partial tears, and they did a bicep tenodesis just because, basically. Now he's 2 years out. He never did physical therapy appropriate enough to get him back to lifting, and he still has signs of rotator cuff tendinopathy. So I just think we have to do something about this. So right now, I'm very, very passionate about rotator cuffs. I also feel like a more simplistic approach is something that can benefit a lot of folks, and a less medicalized approach can benefit a lot of folks. So right now, I think that's where my time is rotator cuff and rotator cuff tendons. Maybe in the future, maybe some hip stuff. I kind of like it, but it's honestly very complicated though. But I have had some success with like hip flexor tendinopathy, adductor stuff, glute tendinopathy, hamstring stuff. There's some interest there, but I think for the near future, I think it's gonna be rotator cuffs.
Hmm. I know I said that's the last part, but like since you brought all that, uh,
Yeah.
what's really interesting is my wife actually have, uh, I don't know if it's true or not, but like she had really bad shoulder pain like 3 years ago, and so
Uh-huh.
we she went to the doctor. They
Yep.
couldn't figure it out, so did an MRI.
Yep.
So like same story, like a rotator cuff tear or something like that. Did a repair, did like RPR, all that stuff. Still pain, still super painful. After all that, all that money, nothing really works. So we change our way, go to physical therapist, do some like rotator cuff exercise. That actually works. That no
It's
pain
amazing.
now.
It's
Yeah, no
amazing, right?
pain now, right?
It what
Same
is
story
it's the exact same story. I hear it over and over again, and it's not just in the US either. It's literally all over
everywhere.
the world.
Everywhere.
Everywhere. This is I hear these stories in Europe, I hear these stories everywhere. And so and the other thing is too is like once the medical system runs you up that ladder, and then you still have symptoms. And this is what happened to the guy I was just speaking with. Then he goes back in and they just throw their hands up because they're like, well, we already did a surgery. We already did the injections. You already did quote unquote PT, even though it's usually, not appropriate physical. It wasn't appropriate to actually build those capacities and tolerances that we were talking about. And then you go back into the medical system and you know what they suggested? Another MRI. And the guy said, what? What? I'm starting back at the bottom of the ladder. I know exactly what's going to happen. And he was intelligent enough to know, like, maybe I actually don't want this MRI because he said it goes two ways. One, they
Again.
see nothing. And then I'm like, oh, this is all in my head. Two, they see something. And now I'm thinking I need another surgery or something like that. And he's like, both of those are going to be my downfall psychologically. And I said, absolutely, dude. Absolutely. Why would you go back through that process? It makes so much more sense. And the thing is, then we were on a virtual call and I was able to immediately trigger his symptoms with the assessment that I talked about. Whereas the orthopedic surgeon couldn't do it with all of the special tests. And he went to see somebody else and they were like, oh, we don't know where to inject because we can't palpate
Yeah.
soreness. And I'm like, just use a load-based test and then you'll see, oh yeah, there. So yeah, it's so common, and that's why I think maybe right now, like it's very needed to change this conversation.
Nice, nice. I love it. I love it. So, uh, obviously, like we talked about, there's a few NBA team interested in your stuff,
Hmm.
and a few a few guys are really like enjoy your stuff. So I believe there's gonna be more and more. So for those people who are interested in like the rotator cuff protocol, where can
Yeah,
they find you? Where can they find the ebook?
yeah. I appreciate that. That's very exciting stuff, man. So easiest place probably Instagram. So tendon RX is my handle. There's a link in the bio. Easy way to buy a protocol there. I think it's up on my website as well, tendonrx.com. And then if anyone, so the protocol is there to, it's a self-directed program. So if someone is dealing with shoulder pain, they're able to walk themselves through. But the other reason I made it was kind of for what you're discussing is to be able to help maybe other providers, but also strength coaches, because I think that honestly, that's the first line of defense for this stuff. Like, I think that one of the best ways we can do to prevent the over medicalization is to allow that person who sees it at first, which is usually the strength coach, is usually the person who's going to see, and then they're actually able to modify maybe the most important modifiable factor, which is the loading. And so my hope is definitely that that would spread into the strength coach world and that those folks are able to make the changes necessary for their athletes, their clients, whatever, to be able to basically do tendon rehab without us having to go up that ladder. So yeah, that's where they would find it. And absolutely, my hope is that folks will check that out.
Yeah, nice, nice. That's all the question I have here today.
All right. Thanks for having me on. I appreciate it.